Next, we have the great pleasure of Dr. Javier Rangel from KP San Francisco and our Northern California Melanoma Program Chair for Dermatology to help share his thoughts on melanoma prevention. Thanks, Javier.
Hi, Takia. Thanks for introducing me, and thank you for inviting me. Thanks to the AIM at Melanoma for having me give a presentation and talk. It's nice to be back, and hopefully again in the future in person. Let's see, I just wanted to start sharing my screen here. And I'm a dermatologist and dermatopathologist, and it's a pleasure working with everyone on the tumor board here in Northern California. I really enjoy the diversity of my different roles. I have kind of different hats, and so it kind of keeps things interesting. I see patients on some days in the clinic, and I see a lot of pigmented lesion patients, patients with melanoma, and I really enjoy that. I really enjoy the patient interaction. And on other days, I am in the pathology laboratory, so I'm seeing challenging consults from all over Northern California. Second opinion consults on melanoma, skin cancers, different difficult rashes, and so it just really keeps it very interesting. And so today I just wanted to briefly talk about different causes and epidemiology incidence of melanoma, tips for prevention, and also just like technological innovations and things that have come out recently. So this is, just kind of the things that I see in the clinic or that come along our way in the tumor board. Many of these are patients I've had personally, and so melanoma can have different appearances. It can be very large pigmented lesions, kind of like the one on the left, with nodules, different colors, and they're very suspicious appearing. Sometimes they could be kind of red or bleeding lesions on the scalp, of uncertain etiology to a patient. They might have thought they traumatized their scalp or something happened, or an injury. So they can really have different faces and appearances. So a little bit about melanoma in 2023. It's estimated that there's going to be over 7,000 deaths due to melanoma this year, and it's really one of the surprising things. It's the leading cause of cancer death in young women, 25 to 30, and the second in the cohort of 30 to 35. So it's very, very common, and something that we're trying to increase awareness about. And so I think that's why giving this talk and giving this cancer prevention talk is I think of key importance. And in terms of like total incidence, there's almost 80,000 new cases of melanoma that are predicted to come out this year. So it's been slowly increasing. Just a kind of comparison, there's really the three most common skin cancers. Really the most common is the basal cell skin cancer. And when people think about this, I tell them that that's the wimpy skin cancer. That's the type of skin cancer that's very, very common, very indolent, slow growing, can take years to really manifest. And really in terms of death and morbidity and mortality, it's much lower. There's very few deaths due to basal cell. Because it can be very surgically amenable, even topically treated sometimes. Squamous cell carcinoma, cutaneous squamous cell carcinoma, on the other hand, is less common than basal cell, but it can have quite a bit of morbidity. They can metastasize and occasionally cause death, and more so in the immunosuppressed populations. Melanoma, on the other hand, is much less common. However, it does account for many more deaths than the other two more common types of skin cancers. So there's the triangles in terms of incidence and deaths really kind of are inverted to each other, as you can see by this graph. And in terms of epidemiology, like I was saying, the lifetime risk of melanoma, it used to be 1 in 50 here in the U.S. Now it's kind of slowly increasing to 1 in 40 for white persons, but still pretty common for Hispanic and Latino and Asian descent, 1 in 200, and for African American persons, it can be 1 in 1,000. So, people can recall Bob Marley passing away from melanoma. And the risk factor really is higher if you have a family history. So a first degree relative, a sibling, a parent. If you really have excess UV exposure, so a lot of, history of tanning as a child or tanning bed use, 5 or more blistering sunburns as a child. And your immune system status is of high correlation as well. So organ transplant patients, people on immunosuppression. And like I said, I really want to focus on some of the causes like UV radiation, which really accounts for a huge percentage of melanoma. And so the amount of sun exposure, the chronicity of your sun exposure, like, if you work outdoors, if you're an avid outdoor enthusiast, like a boater or a hiker, if you're not wearing sunscreen or being cautious if you go to the beach. I used to live in Pennsylvania, and I would see a lot of people from New Jersey. So the Jersey Shore people can get very, very sun exposed and a lot of sun damage. So some of the causes really the UVB rays. Those are the rays that really account for burning. So they contribute to the sunburns and also wrinkles. But UVA is what's more responsible for skin cancer. It can cause a lot of DNA damage, wrinkles, and UVA is what we use for tanning beds. So that can cause a lot of sun damage in our DNA and mutations that kind of accumulate and lead to tumorigenesis with skin cancers and especially with melanoma. This is a slide that I like to share because there's kind of genetic evolutions of melanoma, and this is a lot of what I deal with in my pathology is determining benign moles from malignant moles and kind of the in between. There's a gray zone. So there's obviously very benign moles that are present at birth or develop as acquired, but then there's very obvious malignant tumors, kind of like the photos that I showed you. But there are these so-called dysplastic or atypical moles that kind of fall in between. They're intermediate, and we're not fully sure if those evolve into melanoma or if they're kind of signs of a risk for melanoma. But we do know that they develop mutations, and so those intermediate atypical moles can have mutations in BRAF and other important genes also involved with some of the driver genes that we know about that are also targeted therapies. But as they accumulate more and more UV damage and more mutations, copy number alterations, they become invasive, or they can become malignant and then invasive. So this kind of just shows that there's a spectrum. There really is a spectrum. And so, getting back to, how do we prevent this damage? How do we lower our risk for melanoma? Really, the thing I tell people every day in my clinic is you got to use sunscreen, and I ask what type of sunscreen you use. Really, the best sunscreen to use is the one that you're going to use every day. So, you want to try different types of sunscreens. Like I have quite a few that I try on my kids. Lately, they've been liking these little roll-on bars. They look almost like deodorant bars, and so they're really just easy to kind of paint on. They rub right on their zinc, so they look a little bit pasty, but they really blend in pretty well. So really the easiest one, the one that you're going to use every day that you won't forget, I put it right by my toothbrush. I have a little sunscreen there. So just kind of making it easy to remember and placing a few throughout the house so that you just get accustomed to it. Obviously avoiding tanning booths and self-skin exam. I tell everyone with skin cancer once a month, look at your skin, get undressed after the shower, and just examine, have somebody look at your back. And then when you go to the doctor for a physical, undress. I think it's a good thing to have a gown, undress, have them look at your skin while they're listening to your heart, to your lungs. Those are very key moments to really have a sunscreen with, a trained physician. And as I'll mention, there's other tools that can be used. So For sunscreen, like I was saying, really SPF 30, the one that you're going to use is, I think, the best one. And they have UV protective shirts. I just recently went to Hawaii, got some UV protective shirts. You can really protect your skin that way as well. And it's SPF 30 and broad spectrum, water resistant. In Hawaii, they have certain restrictions on the type of sunscreen you can use, but I think really the one you're going to use is the best one. So these are some tips on how to protect your skin and self-screening, as you really want to look all over your torso, your arms in a mirror, your scalp and neck. I mean, especially if you go to the hairdresser, and you'd be surprised at the number of referrals I get from people's hairdressers, looking just at every nook and cranny, every crevice, once a month, and especially your palms and soles if you're of Latino, African American, or Asian descent. A little bit about appearances: the ABCDES of melanoma, asymmetry. You can really a picture is really worth 1,000 words. You can really see how irregular versus something that you can cut in half and fold onto each other. And especially if you have borders that kind of look like the coast of Alaska, that's very abnormal. Multiple colors, and especially if you have one that's bigger than a pencil eraser, so the diameter, and something that's evolving. And really the evolution, I think, is of key importance for melanoma survivors, because brand new moles that develop afterwards are an abnormal sign. And technology, I mean, like, if you're going to a primary care doctor, they might not know the exact answer about what you have or the type of mole you have, but really teledermatology, we've been leveraging this over the past few years, even before COVID, but especially now during COVID, and that primary care providers, especially in our institution, are really well equipped to take photographs. They can even take very close dermatoscopic pictures, meaning like a magnified picture, send it to our expert dermatologists. We have really a big team of teledermatologists working every day, analyzing these pictures and providing recommendations, management, even expediting appointments when necessary. So really, this has allowed us really to identify more skin cancers even faster with fewer visits. So it's really the best of both worlds. It helps the patients, help us. It really kind of leverages technology. And there's other technologies evolving. There's full body mole mapping and total body photography. There's AI coming into the picture, and that's kind of helping us prioritize things. So these are things that are being trialed, especially in Southern California. They're really trialing machine learning for prioritizing teledermatology. There's dermoscopy. Like I said, we can transmit these images and give expert advice, and non-invasive gene expression profiling, where like little tape stripping technologies, and we can pick up things without doing a biopsy. And so at Kaiser, we have a large survivorship program among our 4 million plus members, a really fully integrated healthcare system. And we have a multidisciplinary committee that develops tools such as our melanoma tracking dashboard to really meet our surveillance goals and our follow-up goals. So that's been really a wonderful innovation with our group and our system. And of course, with melanoma survivorship, we really want to make sure that we increase the quality of care. We detect new melanomas earlier, and it really improves survival and quality of life. So thank you so much for your time, and I hope you enjoyed this presentation.
Thank you so much, Javier. This was a great talk. I learned a lot. There is so much new technology, really a positive part of the pandemic, I think. I mean, very similar to my talk with Marie, right? That there were many things we wanted to do for a long time, have patients get treatment closer to home, not have to go in and out and wait in line for appointments very long. If the positive part is that we managed to get all that done after, I do really love that. So thank you.